I am delighted to welcome you to our second annual World Ovarian Cancer Coalition partner meeting. Thank you for joining us. For those of you that do not know me, I am Annwen Jones, Chair of the World Ovarian Cancer Coalition. For those of you who may not be familiar with the work of the Coalition, we are a global network of almost 200 patient advocacy organizations representing some 51 different countries worldwide. Our vision is a world where every woman diagnosed with ovarian cancer has the best survival and the best quality of life wherever she lives. I hope that you will find this year's meeting informative and stimulating. Over the next 2 days, we will be sharing updates on ovarian cancer research, treatment, and policy. We will also be sharing case studies from a number of partner organizations that represent excellence and innovative practice, as well as updates on World Ovarian Cancer Day 2023 and the Every Woman Study Low and Middle Income Country Edition. Truly, we have an outstanding lineup of contributors. Our aim is to offer a program that acknowledges the much welcomed advances we have seen in ovarian cancer in recent years, as well as the magnitude of the challenges that we still need to overcome. It is a genuine honor to work with all our global partner organizations and to showcase the excellent work that you do. I'm delighted that we will be commending some of your amazing efforts as part of our second annual Impact Awards, which we will be awarding at a special ceremony at the end of this meeting. Huge congratulations to all of you for the truly outstanding work that you do. Before handing over to our CEO, Clara McKay, I would like to thank all that have made time to contribute to our meeting, as well as our sponsors of this event. As always, we greatly appreciate all that you do and could not do our work without your support. With that, I will hand over to Clara. Thank you.
Thank you, Annwen. Really happy to be back hosting the second annual Coalition Partner Meeting. Welcome to all, and I echo your thanks to our corporate sponsors for making this possible. So we're starting the meeting with a session on clinical updates. And earlier this month, it was my great pleasure to speak to two key leaders in ovarian cancer research. In the next two segments, you'll hear about the latest developments in platinum-resistant ovarian cancer and an update on PARP inhibitors. While these segments are pre-recorded, if you have any questions, please pop them into the chat box on the right. We're keen to hear your views and we're keen to have a discussion, and we'll make sure that we get answers to any questions that you post that we may not be able to respond to immediately. Thank you. Welcome to this clinical update on platinum-resistant ovarian cancer. This is an area of ovarian cancer where we have high unmet need, and that impacts a significant number of women and indeed their outcomes. So I'm pleased that we're able to share today some recent updates in the treatment of platinum-resistant ovarian cancer, and I'm delighted to be joined by Ursula Matulonis, who will take us through that update. Ursula is Chief of the Division of Gynecologic Cancer at Dana Farber Cancer Institute and Professor of Medicine at Harvard Medical School. So Ursula, welcome. Thank you so much for making time today and for sharing an update.
Great. Thank you so much for inviting me to present to such a great organization, and welcome to everyone who's out there listening. So there's a lot to talk about around platinum-resistant ovarian cancer, and you've already heard definitely an unmet need in this type of place where women find themselves at recurrence. And I'm also going to talk about an antibody drug conjugate called mirvetuximab soravtansine, which just received accelerated approval through the FDA's accelerated approval plan on November 14th, 2022. So just a few words about platinum-resistant ovarian cancer, and I think it's been typically defined by having a platinum-free interval of 6 months or less. So meaning that somebody will receive platinum and then will determine to have a recurrence within the next 6 months. And as we know, that way of making that determination can be simply by checking CA-125, maybe going from 8 to 12, or somebody having surveillance CAT scans, which shows some growth, or even to the point where somebody develops clinically significant growth, such as a bowel obstruction or a significant, clinically significant pleural effusion or ascites. We do know that the treatment options for platinum-resistant ovarian cancer have been limited, and really have been limited now to chemotherapy. Over the 2022, the PARP inhibitors have been removed as treatment for BRCA mutated or BRC mutated ovarian cancer, at least in the United States. So we are left with chemotherapy, single agent, and then single agent chemotherapy, but now it added bevacizumab, so combination chemotherapy plus bevacizumab based upon the Aurelia study. And this is, again, this is not new data. This is really presented a number of years ago, leading to an FDA approval a number of years ago as well. Response rates are low, but they are better with bevacizumab added in. And you can see from this bottom table that really weekly paclitaxel plus bevacizumab, results in a 53% response rate with a progression-free time survival of almost 10 months. So quite an active regimen. And that really is our bar where we have to look to if we're going to develop medications and we're going up against weekly paclitaxel bev, or do we go after that as well? And those are kind of thinking strategies around drug development. I want to talk about FR alpha or folate receptor alpha, mirvetuximab, soravtansine, and then the SORAYA study. So FR alpha, which is also known as folate receptor 1 or FOLR1, as you'll see on the companion diagnostic that's come out with mirvetuximab, has limited expression on normal tissues, but it's elevated in most ovarian cancers, specifically high-grade serous. And it makes FR alpha really an attractive target for the development of novel therapies. The single agent maximally tolerated dose, meaning the dose that we're going to use, of mirvetuximab, 6 milligrams per kilogram, which is calculated by something called the adjusted ideal body weight. And the SORAYA study, which has been presented in a number of different avenues or congresses through 2022, is a global single-arm pivotal trial that evaluated mirvetuximab for the treatment of platinum-resistant ovarian cancer in patients with high FR alpha expression on their cancers who had received up to 3 prior therapies, including the requirement for receiving prior bevacizumab. As I mentioned, mirvetuximab soravtansine just recently received an accelerated FDA approval on November 14th for the treatment of platinum-resistant ovarian cancer with FR alpha high expression in patients who have received up to 3 prior lines of therapy. So this is the SORAYA study. It's a trial to really evaluate the efficacy and safety of mirvetuximab in patients with FR alpha high. So this is really specific, and we'll talk about the companion diagnostic. The primary endpoint was overall response rate by the investigator. So what we thought folks were having as a response rate, not by a blinded independent review. There was a blinded independent review, but it was with what we thought was. The key secondary point for those responses, how long was the response? So what's the duration of response? And these are the women who were enrolled into the trial. Platinum-resistant ovarian cancer, as I mentioned, recurrence within 6 months after last platinum dose, treated up to 3 prior regimens. Women who has their cancers were growing, actively growing on platinum, were excluded. I mentioned high-grade serous histology, receipt of prior bevacizumab, and importantly, the tumor had to have FR alpha high membrane staining. So this is an IHC stain. This is not a sequencing test. This is a test that the pathologists do, put a stain on and call it. So it has to be something called, it's through a PS2+ scoring. So 75% or higher of the cancer cells had to stain positive with at least 2+ staining intensity, 2 to 3+ staining intensity. And that's critical. That has to be present in order for the drug to be used. We've talked about the treatment schedule, and this is how the sample size was calculated. 105 patients enrolled, really to look at a response rate. If we were looking for a response rate of 24% versus 12% for chemotherapy, that would have been considered a positive study. And these are the folks who are included. All patients were included, 106. That was a safety population. 106 patients received at least 1 dose. 105 patients were efficacy evaluable, meaning they could be evaluable for response and duration of response. And then these are the different characteristics. As I said, all patients had prior BEV. About half the patients had received a prior PARP inhibitor. This is the overall response rate was 32.4%. So this surpassed the expected, or what we thought was going to be the expected response rate of 24%, which would have been a good response rate. So 32.4% is even better. There were 5 complete responses, which is, really, I think, remarkable for women who have platinum-resistant ovarian cancer, heavily pretreated, 29 partial responses. Around 45% of patients had stable disease. So, stable disease encompasses also some reduction, but doesn't quite meet that 30% as determined by the RECIST criteria. So here on the left is that 32.4% response rate. And we looked at 2 subgroups. One was the number of prior lines of therapy, 1 to 2 or 3, and then receipt of prior PARP inhibitor. And really there was not an impact based upon the number of prior lines or receipt of a prior PARP inhibitor. The median duration of response was a very good 6.9 months. And what we saw also that based upon those subgroup analysis, that the number of prior lines of therapy nor receipt of prior PARP inhibitor impacted that duration of response. This is, we call the swimmers plot, and shows you all of the patients who had a response to treatment. And those little black dots represent when that response started. So the first response was the black dots. You can see really at the time of the first assessment, we're seeing a number of patients having a response. So the response is happening quickly. And that's really important for platinum-resistant cancer because sometimes there's symptoms starting from the cancer or there are already overt symptoms. So you need a response quickly. You can't wait months to get a response. These are some of the treatment-related adverse events. So really the adverse events were primarily low-grade reversible eye or ocular toxicities and gastrointestinal events. The most common side effect, 41% of patients had blurred vision. It was grade 3, so symptomatic state in about 6%. Keratopathy is what the eye specialist sees, either an optometrist or an ophthalmologist. 30% had some keratopathy on eye exam. And that keratopathy is defined by below. And most of the times, there are corneal cysts or microcysts. And we'll talk a little bit about that. The most common GI toxicity was nausea. Nobody had grade 3 or grade 4 nausea. Fatigue, 24% of folks had mostly grade 1 or 2 fatigue, only 1% grade 3. Diarrhea, peripheral neuropathy because of the DM4 linker. So mirvetuximab soravtansine is a antibody drug conjugate. It targets with DM4, and DM4 is a tubulin targeting agent, but we did not see peripheral neuropathy here and very little heme toxicity as well. So serious treatment-related adverse events happened in about 9% of patients. These led to dose delays in about a third of patients and dose reductions in 20% of the patients. And the package insert for mirvetuximab has a very good way of making sure that physicians know how to dose reduce and when to dose delay. This is the black box warning that has occurred and is present in the package insert from just released 2 days ago. So it talks about the eye toxicities, and it's important on point number 2 to conduct an ophthalmic exam, including visual acuity and slit lamp exam prior to initiation of Elahere, and Elahere is a trade name for mirvetuximab soravtansine, every other cycle for the first 8 cycles, and then is clinically indicated. So that's what we're going to have to do. And then it's going to be important to administer prophylactic artificial tears as well as topical steroids. So the ocular toxicities are off-target effects on the cornea. So what happens is DM4, which is the drug that is tagged to the FR alpha antibody, reaches the cornea through the limbal or peripheral regions of the cornea. Those cells are damaged. They migrate centripetally into the center of the cornea, cause these microcysts, and either the drug may need to be reduced, held, and eventually the cornea repairs itself and the corneal cells are replenished within about 7 to 10 days. And that's what we see typically when you dose, reduce, or hold. The blurred vision gets better typically within a week. And the steroids can probably slow down the proliferation of these limbal stem cells that are at the outsides of the cornea where that DM4 gets incorporated. Those cells get damaged, and I mentioned get into the center, and that probably can slow down the proliferation of those cells. So in conclusions, mirvetuximab demonstrated really clinically meaningful anti-cancer activity in patients with FR alpha high platinum-resistant ovarian cancer. We saw a response rate 32.4%, much higher than what would be expected with single-agent chemotherapy, which is around 10% or lower. Median duration of response, 6.9 months. And most of those responses are happening quickly at the first assessment. The toxicities are low-grade reversible ocular and gastrointestinal events, which are manageable with supportive care. We did not see significant myelosuppression, and we saw very limited low-grade neuropathy. Here is about 9%, 7 to 9% discontinued treatment due to treatment-related adverse events, and only one patient discontinued due to an ocular event. And I might add that patient who discontinued because of an ocular event, when she stopped the drug, her side effects got better very quickly. So we're very excited to be the first drug to have an approval, FDA approval. Granted, it was on the accelerated approval mechanism since 2014 for platinum-resistant ovarian cancer, and the uses in platinum-resistant ovarian cancer with FR alpha high expression. And these are some of the ongoing trials of mirvetuximab, the top one being the most important. This is the confirmatory trial that has to show positive results in order for mirvetuximab to receive a full approval. But if you dig through the press releases and the package inserts, the FDA had really mandated that some of the results of MIRASOL be examined prior to publication or presentation, showing that the MIRASOL trial was going in the correct direction. So that's public information. So very reassuring. Thank you so much.
I wonder, do you feel has the work that's been going on in platinum-resistant ovarian cancer given us a better understanding of the biology of the disease? Have we made a bit of a leap on that front?
Yeah, platinum-resistant ovarian cancer is difficult. It's difficult. I think that the exact mechanisms of how the cancer cells become more resistant to platinum is just not well understood. I think we're understanding how to treat it better with the reuse of platinum, even if the cancer is platinum resistant, really because of the issues I mentioned previously, that a lot of times we're calling platinum resistant based upon CA-125s moving just a few points, check a scan, you see something there, consider platinum resistant. So platinum can certainly be reused. I think antibody drug conjugates are going to be a really important therapy for our patients, because it really looks at expression, membrane expression of certain proteins, which you can target with FR alpha, other targets being studied now. Immunotherapy has been, to date, not particularly active. The checkpoint inhibitors, which have been shown to activity in other cancers such as melanoma, non-small cell lung cancer, have very low response rates, and in randomized trials have not had a significant impact and have not received any approvals, especially in high-grade serous ovarian cancer, unless you find that the tumor mutational burden is greater than 10, or that rare microsatellite unstable or mismatch repair deficient cancer, which what we'll see in clear cells, in low-grade endometrioid, sometimes in mucinous, but not in high-grade serous ovarian cancer. So we definitely need new strategies to really try to get the immune system to wake up and recognize high-grade serous ovarian cancer cells.
Yeah, that's really helpful. And so where next, do you think, for platinum-resistant ovarian cancer? Should we be hopeful for more developments? And
so I think one of the hallmarks of high-grade serous ovarian cancer has been around abnormal DNA repair. Certainly, PARP inhibitors have had some impact, but as I'm sure you're going to hear from Dr. Monk, there has been a dialing back of the FDA approvals, at least in the United States, of the use of PARP inhibitors in non-BRCA mutated cancers. So in the non-BRCA mutated cancers, where we definitely see this concept of underlying homologous recombination deficiency, we're going to have to show not only efficacy, but the maintaining of long-term survival of our patients, and then also mitigation of acute myelogenous leukemia, MDS risks. So there's a lot of work to
There's
do.
a bit of work to do.
There's a bit of work to do, right?
Thank you so much. That was a brilliant update, really, really helpful, and again, very timely. So thank you so much for your time and for sharing
You're
that with
welcome.
us today.
Thank you so much for inviting me.
So welcome to this update on PARP inhibitors. It's such an important and topical discussion for us to be having. And I know that all of our member organizations, and indeed all that are in attendance today, are interested in this subject. I'm really delighted, and I want to welcome Dr. Bradley Monk, gynecologic oncologist and professor at Arizona University in Phoenix, Arizona. So welcome, Dr. Monk. Thank you for making time for us today. So perhaps a good way to kick off would be if you could just briefly kind of tell us about your involvement in the development of PARPs. And then I know that you have a slide deck that you're going to take us through and give us an overview of where we are today. So I'm going to hand over to you.
Claire, I'm a big fan of your organization, and thank you for all that you're doing individually, but for everything that your group is doing globally. And so I'll always be here to help you or any of your members in any way. As a younger man, I wanted to change the world, just like you want to change the world. And the way to change the world is to keep patients in remission so they can live longer and live better. And as a result, I co-founded the GOG Foundation, which is one of the largest nonprofit organizations doing gynecologic cancer research. And I'm co-director and vice president of that. So I'm honored to be with you. I want to take you on a journey, but before I do, I work with all of the sponsors and companies, but this is my message, and they're not paying me to talk to you. And I'm going to give you a independent, hopefully unbiased and clear message, because any fool can make something complicated, but it's hard to keep things simple. And that's what we try to do today. My first message is that ovarian cancer is not one disease. And if you or your loved one or your friend are fighting ovarian cancer, you got to know what kind of ovarian cancer they have. And we'll share these slides with you because I'm going to go quickly. But this is the first concept that there are various types. The most common type is a high-grade serous cancer. It's really fallopian tube cancer, after all. And it's not just the type of cancer, it's the molecular alteration. Cancers are driven by genes like every other cell in your body. And not only do you need to know the type of your cancer, but you need to know the genes that are driving it so we can turn them off. And if we turn off the genes, we turn off their growth. Now, I'm happy to report that the number of cases, the incidence year over year is falling. It's falling predominantly because we ask OBGYN doctors to take out the tubes for contraception rather than interrupt them, to tie them, if you will. And what Angelina Jolie did is that she taught us that you can know your family history, get tested, and also have a risk-reducing surgery. And as a result, there are fewer cases and there are fewer deaths, down almost a third, but there are more women fighting it. The prevalence is the number of women that are fighting it every day. It's increasing, and it's increasing because we have new medicines, because we collaborate together in a research and advocacy environment. And these new medicines became online about 2014. And I'm talking to you about that and take you on this journey. We have PARP inhibitors through this landscape. We even started to just use more chemotherapy to keep patients in remission. That doesn't make any sense. It's toxic, alopecia, bone marrow suppression, neuropathy. And then we developed bevacizumab, which I'm going to share with you, which is an antibody that blocks and inhibits the molecule that causes blood vessels to feed the cancer. So we can choke off those blood vessels, then they starve, and patients can live longer and better. And then there's this PARP journey that I'm going to share with you in a very succinct way, but it all starts with chemotherapy. And I don't know if you're familiar with these Kaplan-Meier curves, but in the beginning, everybody is alive or free of cancer, 100%. And over time, there's a decay. And the best chemotherapy today is intravenous, not intraperitoneal. It's given every 3 weeks, not weekly. And this was a trial that tried to address some of these nuances in the every 3 week schedule of carboplatin. It's platinum, it's a metal, it's toxic, specifically to ovarian cancer cells, and Paclitaxel, which used to be known as Taxol, which is made from the bark of the Pacific yew tree, that was to protect the tree from insects, and it killed the insects, and now it kills ovarian cancer together as a combination. We wanted to add something to it other than chemotherapy that could be given for a long period of time, and it was this medication, bevacizumab. It was published in the New England Journal by our group, the GOG, in 2011 in the best journal. It's the New England Journal of Medicine, if you haven't heard of it. And it got approved around the world, but not in the US. It didn't get approved in the front line with chemotherapy and in maintenance to keep people in remission until 2018, because we had to prove to the FDA that the time to progression was what is important, not the survival. And there's this big disconnect recently that if you can't show that patients are living longer, it's not worth it. But I showed you, you are living longer. And it's not one thing. It's not just chemotherapy. It's not just bevacizumab. It's not just PARP inhibitor. It's not just surgery. It's not just radiation. It's yes. So we can delay with the use of bevacizumab 6 months. This is what you get if you get chemotherapy. You're on this line. And we talk about hazard ratios. Hazard ratios are the difference at any given point of the green line with bevacizumab versus chemotherapy placebo. In this line, the green line is 38% better. Hazard ratio 0.62, 0.62 minus 1 is 0.38. It's 38% better at any point. And that wasn't enough. The reason it's not enough because bevacizumab has no biomarker. I don't know who it works the best in. So we had to learn more about ovarian cancer. It's driven by science, right? It's driven by science. We had to figure out how the DNA was repaired, how it was mutated. And we did this through looking at all sorts of methods and techniques that you repair your broken chromosomes. And one that created particular leverage was double-stranded chromosome break. Remember, the chromosome is a double strand, and you can either have a single strand break or a double strand break. And the way we create single strand breaks is with a PARP inhibitor. It's an enzyme that repairs single stranded breaks. And what happens is it's more active in patients that have BRCA. It's 1,000 times more active if you have a BRCA mutation in your tumor. Why? Because if you inhibit a single stranded break, it becomes a double stranded break, and BRCA repairs double stranded breaks. So you have to have both. You have to have inhibit PARP, and you have to have the inability to repair double-stranded breaks, which is exactly what BRCA does at its core. And there are other BRCA-like genes which can be measured. And this measure is called homologous recombination deficiency. When you break one chromosome, it lines up to the sister. Remember, you got 2 chromosomes each. The sister chromatid, the homolog, and recombines it. And if you can't fix a double-stranded break, you're homologous recombination deficient, and you can measure it. And that's a tumor test versus BRCA, which is a blood test. And so everybody needs germline testing, figure out what's going on in your family, and then test the tumor, figure out what's going on in the tumor. And this is not just a US-based philosophy and guideline, it's a global guideline. So we have 3 PARP inhibitors in the clinic. They're not all the same. Don't let anyone tell you that they are. And your doctor or your patient, your friend's doctor, or family member's doctor can help you figure out which one is the best. They have different FDA approvals, and it's very difficult to use a medication that's not FDA approved, and we'll get into that. They sort of have all the same side effects, but to varying degrees. It's sort of 3 categories: hematologic, bone marrow, intestinal, and fatigue. There's some rare, can even cause leukemia in about 1% of patients, but that's unfortunate. But in an almost 100% lethal or 80% lethal ovarian cancer patient, it justifies that risk. I'm not going to get too much into the side effect profile, but they're different. Again, bone marrow, fatigue, GI, intestinal. And there are these studies that we've done, many of which are GOG. And I'm so honored to be a part of this wonderful organization. And the granddaddy of them all, at least the first one, was SOLO-1, which again took patients just like bevacizumab that were responding and gave them in maintenance, but only if you had a BRCA mutation, because that's where PARP inhibitors are supposed to work. And we did that, and it had a dramatic, look at this hazard ratio, 0.33, a 67% improvement at anywhere along the curve, okay? And then we just went to Paris and looked at the long-term survival. And indeed, this particular medication helps patients live longer. And so this is the biggest no-brainer ever to give a PARP inhibitor in a patient that has a BRCA mutation, either in her germline, which she was born with, or in her tumor. You got to test both. And again, a hazard ratio of 0.55. And there are actually 3 now in this space. And I'm going to show you niraparib and rucaparib. So there are 3 opportunities here. And it got approved. It got approved again, just as we started that inflection in the number of patients that were living longer, 2018. Okay. Niraparib is the same sort of concept given in maintenance. It's once daily. Olaparib is twice. The dose for niraparib is individualized. If you're littler, you get a littler dose. I know that sounds like so fundamental, but olaparib is a fixed dose. And it works not only in those that have a BRCA-like mutation. Remember, olaparib is only BRCA. The HRD population that I described with a hazard ratio of 0.43 works in everyone. Wow. Works in everyone. So why would I test the tumor if it works in everyone? I want to set the expectation. I want the patient to know what they're getting themselves into, whether they have a BRCA, whether they have HRD, or whether they just have ovarian cancer. So this was, again, it works better in the BRCA, but even in the non-BRCA, it works pretty good, regardless of the molecular signature. And this, again, was also just updated in Paris and shows a consistent long-term benefit. And not enough patients have died. Isn't that great? To tell you whether they're living longer. Remember, Solo 1 was number 1. And so this is a consistent effect, and we're very happy that it's working. And it got FDA approved in 2020. And then ultimately someone said in Europe, because they had bevacizumab approved in 2011, remember we didn't get it until 2018, why don't we do both? Why don't we do bevacizumab and olaparib together? And so the French did it, and it worked. And it worked, but only again in the HRD positive subset, okay? And you can be HRD either by having a BRCA mutation. All BRCA is HRD, or if you don't have a BRCA mutation. But if you're not HRD, it doesn't show effectiveness. So the idea is start your bevacizumab, test the tumor, and if you're HRD, add the olaparib onto it in the maintenance phase. And if you're not, then just keep the bevacizumab going. And this was also just updated. Again, in all comers, it's not effective, but in the HRD subset, there's also a survival advantage. So again, patients are indeed living longer. Solo 1, Palo 1. Palo 1 is olaparib and bevacizumab. It's one of my favorite regimens because we want to go full court press in the beginning. And it got FDA approved in May of 2020. And we don't have a single medication approved since. It's been 2.5 years. So we're not giving up. We keep working. I just presented this at the American Society of Clinical Oncology, which is Athena, which is the third PARP inhibitor, rucaparib. It looks very similar to niraparib. And I'll just keep rolling here quickly, but very big benefit in the HRD subset. This is the third option, and also in all comers. So in all comers, you can either do bevacizumab, but we like PARP inhibitors. So if you're HRD, you should get bevacizumab and PARP. And if you're not on Bev, you can either get niraparib, or now you can get rucaparib. Very exciting. And again, the same thing, works better in BRCA, still good in HRD, non-BRCA. And if you're don't have any molecular signature, it still works and justifies the cost and the inconvenience. Remember, this maintenance idea is supposed to be the holiday from side effects, and it is, because the quality of life is the same. Doesn't mean we don't have to tweak the dose. Okay, that happens. But it's the holiday from the cancer, because it is a catastrophic event to have advanced ovarian cancer. And we can put you in remission with chemotherapy, and then we can keep you in remission with bevacizumab, olaparib, or both. So these are the indications. Again, if you're BRCA, you can get either medication or the combination, my favorite. If you're HRD, you can either get either single agent or the combination. And if you're not HRD, or what someone would call HR proficient, you can get Bev or either of the PARP inhibitors. So this is a game-changing sort of paradigm shift. And so now I'm going to tell it to you again. You go germline testing, and then ultimately you test the tumor. You get your chemotherapy, okay? And if you're not on bevacizumab, you can get the PARP inhibitor, okay? If you're on bevacizumab, you get the PARP in the HRD subset. And a lot of our patients are starting with chemotherapy and having their surgery between the third and the fourth dose. That's okay. You make the bevacizumab decision number 3, and then the PARP inhibitor. It's really not that complicated. And I want you to have these. Now, part of the controversy is we've lost some indications. I would argue for reasons that are very challenging to understand. I don't think it's justified. It's sort of beyond the scope of this talk because we're getting PARP inhibitors earlier in frontline, which is when they should be administered. They can even be administered in platinum sensitive recurrence, but these treatment indications, third, fourth line, there aren't very many of those patients around anymore. And then I refer you to these guidelines that were just released online, September 20th, 2022, published October 20th. And this is exactly what I said. So it's not my message. It's the American Society of Clinical Oncology's message. And hopefully it's your provider's message as they can sort of operationalize it. Now, moving forward, we're adding immune therapy. Immune therapy, which is already FDA approved in endometrial and cervical cancer, pembrolizumab, dostarlimab, durvalumab, 2 checkpoint inhibitors. All these trials are done. And probably the next time we talk, I'll be able to introduce immune therapy in ovarian cancer, which heretofore has not been shown to be effective, but we've done a number of trials. So thank you. It's my pleasure to be with you. I'm here in Scottsdale, Arizona, and I'll stop there and take your questions. And thank you, Clara, for having me today.
Thank you so much. That was just brilliant. And indeed, as you went through your presentation, you kind of touched on some of the questions and issues that come up. So I think one of them would be, and I think you touched on it right at the very end, is where are we going? Where now for PARPs, and maybe a little bit about some of the challenges that are now emerging, I guess, with a number of years use under our belts.
Yeah, so it's all about clinical trials. And the majority of patients with ovarian cancer don't even get offered a clinical trial, yet alone go on one. So clinical trials are out there, and I invite your team to advocate for that. It's very easy to find a clinical trial. There's the Clarity Foundation, for example, in San Diego. You can just call them and they'll answer the phone.
I would say too, I think it's important to say that for many of the member organizations that we work with, access to PARPs is not a reality, and access to clinical trials is even further away. But in this context, absolutely correct.
Why would access to PARP inhibitors be not a reality? Because they're approved in virtually every country in the world.
Yes, I think it would be the countries where even access to sort of the essential medicines as well would be very poor. It's there are very diverse kind of positions.
And that's important. And that's important. And healthcare is costly.
And I suppose that brings me to my very last question, which is you have done such an outstanding job of explaining this, but yet for a woman with ovarian cancer or someone diagnosed with ovarian cancer, it is very complex. And so I guess for the organizations that we work with that support women, how do we help them? Yes. And indeed physicians, I would think many physicians must also be sort of learning this as they go along. Like, how do we help them navigate? What are the important factors that we should be telling them to think about?
Yeah, specialty care number one. You want to, medicine is very similar to sports. Not every oncologist is Tom Brady.
Yeah.
And how do you know? Well, that's a good question. We could maybe talk about that another time. Specialist, you have to advocate for yourself and participate in clinical trials. And remember, life really is all about humility.
I think our experience is that most women are very keen to explore all their options. Good. But again, you're in a very complex position and you don't know what you don't know. And I totally agree. You need really to have physicians who are at the top of their game and who are looking at,
what's the best next step for you. And that might be a clinical trial under someone else's kind of guidance. But I'm mindful that we are just at the right at the end of our time. So I just really wanted to thank you, Dr. Monk. That was an excellent presentation and just a really insightful and thoughtful conversation. Thank you so much. Always helpful to hear from you. And thank you for all you're doing. Thank you. Excellent. All right. Super. Thanks. Thank you again to Dr. Matulonis and Dr. Monk for taking time to explain these important updates to us all.